Hello. Thank you for joining the program today, sponsored by the ASC team of Becton Dickinson. The title, Standardizing Processes, Reducing Variability and Increasing Quality in Your ASC. This is an automatic PowerPoint presentation which lasts approximately 23 minutes. Enjoy the program. Your speaker today is Lena Pearson, a medical science liaison for BD in the Interventional Surgery Infection Prevention Division. Since joining BD in 2006, Lena has been a fundamental link between clinical science, field sales, and the healthcare community by providing evidence-based data with a procedural focus to standardization. Lena specializes in skin antisepsis, prepping techniques, surgical and vascular process improvements, and standardization.
Hello, and welcome to Standardizing Processes, Reducing Variability and Increasing Quality in Your ASC. My name is Lena Pearson, and I am a Medical Science Liaison with Becton Dickinson. Thanks for joining today. The objectives for our presentation today are looking at the trends in the Ambulatory Surgery Center surgical volume, understanding the impact of that volume on HII risk, reimbursement, and accreditation. We're going to discuss the potential benefits of standardization and quality improvement in your facilities. And lastly, we're going to identify some initiatives to facilitate that standardization. So let's begin. To fully understand the impact of surgical volume, we need to address the risk associated with that surgical volume. Surgical volumes are shifting from the inpatient to outpatient settings. Within the outpatient setting, a greater percentage of procedures are now being performed in the ambulatory setting rather than the hospital. As you can see, in 2005, 50 million total surgeries were performed. 29 of them were outpatient. In comparison to 2020 numbers, 65 million total surgeries, with 42 million of them being outpatient. What are these drivers of the surgical volume trends? Well, there are several incentives that are driving this shift from inpatient to outpatient, in many instances directly to that ASC-based procedure. First, site-neutral payments are a recent phenomenon that have led to greater reimbursement potential for ASCs. Hospitals are now reimbursed less for procedures that can be performed elsewhere, and in 2018, hospital outpatient departments were reimbursed for only 40% of a fee for procedures that could be performed in an ASC or physician's office. Surgical costs are lower in the ASC. Advances in pain management, better technology, all have contributed to the transition of procedures from inpatient only to outpatient. One of the key considerations for lifting any restrictions on whether or not a procedure is inpatient only is whether or not that procedure can be performed safely in that ASC. As we're aware, in 2018, there were 6 procedures that were removed from the inpatient only list that can now be performed in an outpatient procedure due to these lifted restrictions. With the shift of procedure volumes to the ambulatory care centers, it is important to have programs in place that are accredited. Infection prevention and control is essential for accreditation. Accreditation depends on thorough evaluation of the facility and the processes in place. It is essential for patient safety and good patient outcomes. During a surveying process, the overarching assessment looks at facilities' written program plans. It provides active surveillance and consistency with the current guidelines. In addition, they examine a number of different things from an operative standpoint. They look at high traffic areas for cleanliness, they evaluate sterilization and disinfection procedures, and they even assess sharp usage and disposal. While infection rates in the ambulatory care centers are lower than those observed after hospital-based surgery, they are still clinically significant. The results presented here are from a retrospective analysis of an ambulatory surgical procedures complicated by HAIs that had required a post-surgical care visit. The main outcomes and measures were rated at 14 and 30 days post-surgical care, and by comparison, the HAI rates of the inpatient setting is around 9.75 per 1,000 patients, in comparison to the 3.09 at 14 days and 4.84 at 30 days after ASC surgery? Is it possible that infection rates will rise along with these ASC procedure volumes? As surgical procedures increase, the scrutiny and financial penalties for HIIs are also increasing. As you can see from the timeline below, 2009, the CMS introduced infection control and prevention requirements. In 2012, Ambulatory Surgical Centers Quality Reporting Program launched, and it was a pay-for-reporting structure, quality data program specifically for ASCs. If we move on to 2014, ASCs were required to report prophylactic antibiotic use to prevent HIIs as part of ASC 5. 2015, Safe Surgery Checklist measure was added as a payment deterrent. 2018, ASCs were no longer required to report ASC 5 or 6 to CMS, although it is still recommended to use the checklist. And in 2019, CMS considers removing several measures by 2022, replacing hospital visits after urology and orthopedic ASC procedures. There is a 2% reduction in Medicare payments for failure to report quality indicators for any given year. Although CMS has delayed implementation of ASC 15, which includes 5 patient experience measures from the Consumer Assessment of Healthcare Providers, they're definitely on the horizon. Patient satisfaction may soon impact quality scores. These 5 measures of patient experience will look at facilities and staff, communication about the procedure, preparation for discharge and recovery, overall rating facility, and lastly, recommendations of the facility. ASCs need to consider how they will adjust their procedures to keep patients safe while driving a high quality and positive patient experience. Variability in practice affects infection risk and the quality of care that we deliver. As you can see from the fishbone diagram, there are a few common themes of risk that we can work on to mitigate through quality improvement initiatives. There are multiple factors that contribute to an HAI risk. Pre-op factors, surgeon factors, environmental, even organizational factors. Each one of these could lead to failure or a reduction of surgical outcomes. What are some opportunities to reduce variation in standardization processes to improve that quality that we're looking for? Well, let's focus on 3 areas to improve in the ASC. Let's focus on these 3: patient, instrument, and IV factors, all playing a role in infection risk. Let's look at skin colonization, the lack of patient cleansing from a pre-op bathing standpoint, microscopic cuts from hair removal, airborne dispersal of hair, and lastly, incomplete skin antisepsis. Are we using our skin antiseptics appropriately according to the directions for use? Looking at instrument contamination, the variability of OR policy and practice, variability of sterile processing. Are we using too much IUSS and reprocessing capabilities, inefficient asset utilization? Lastly, our IV factors and blood exposure, accidental needle sticks, difficulty in catheter insertion or removal, catheter tubing failures, and lastly, poorly trained staff. Let's look at the challenges associated with pre-op patient care and opportunities to overcome those challenges to make quality improvement. Let's focus on pre-op skin preparation. There are a number of opportunities to standardize and reduce variability in the surgical suite. For an example, this observational study below looked at a number of different steps in the infection prevention process surrounding skin antisepsis. With over 6,000 total observations, they were able to look at the skin prep process in regards to a number of different factors. They looked at the skin prep time, the dry time associated, were gloves used, and were those gloves sterile or non-sterile? Hair clipping, was it performed outside of that OR, as with A1 recommendations? Was the skin prep application methodology followed according to the manufacturer labels? And then lastly, that application, did it start from the center and work its way out with good aseptic technique? Why is it so important that we just focus on skin antisepsis? Proper skin preparation is an important preventive measure. 80% of the skin flora resides in the first 5 layers of stratum corneum. 1 in 10 equality between cells in the human body, and colonizing microbial cells creates a major risk factor for an HAI. The skin needs to be properly cleaned prior to procedure to avoid serious complications. Here are 4 opportunities for standardization in skin preparation. That's hand hygiene with compliance, hand and forearm scrubbing, whether that's technique, duration, drawing and gloving techniques. You could also look at hair removal, whether they're clipped inside that OR or outside the OR. And then lastly, surgical site antiseptic. Are we using the proper antiseptic agent with appropriate application methodology and dry time? Let's just focus on skin prep for a moment. There's high variability in patient skin prep processes that may compromise our safety. Observational study below of over 3,000 observations in a hospital setting looked at a number of different preps that were utilized. And what they actually thought was that skin preparation time was only followed 60% of the time according to the directions for use. Gloves used during the skin prep application were only used 91% of the time. And the skin preparation application from the surgical site out to the periphery, or application methodology, was only used 86% of the time. Is this because we have multiple different products with multiple different DFUs? Are we able to reduce the variation and improve compliance by minimizing the amount of products we use? Variability in instructions among patient skin preparation agents may lead to confusion. Below are 4 major antiseptics that are utilized. CHG in IPA or ChlorPrep has an application methodology of a gentle back and forth. Application time is anywhere between 30 seconds and 2 minutes with a 3-minute dry time. Iodine in IPA, whether that's Prevail or DuraPrep, is painted in a circle. It has a minimum dry time of 3 minutes. If we move on to our tried and trues of aqueous CHG, whether that's Exodine or Hibiclens, that application is a back and forth swabbing motion for about 4 minutes with no dry time. Lastly, iodine and scrub and paint, which is our standard 2-step process. It is a scrub in a concentric circle. The application time is anywhere between 5 minutes for that scrubbing motion. You're going to blot, and then you're going to allow that paint to dry a minimum of 2 or 3 minutes to release that favorable iodine. So, as you can see, there's multiple different instructions for use that can lead to confusion. Variability in compliance to skin prep instructions can put patients at risk. An observational study conducted in 257 U.S. hospitals found that 75% of cases, manufacturers' directions for use of the skin prep products were not fully complied with. In more than 1 in 3 cases, neither proper prep time nor dry time was observed. Interesting, this study also found that several factors correlated with significantly higher compliance rates, including 1-step applicator use, central to peripheral application, the use of chlorhexidine alcohol, and performing a single prep versus a 2-step application. Standardizing opportunity number 2 for your ASCs. Let's look at the challenges associated with pre-op patient care and opportunities to overcome those challenges to make quality improvements with IV procedures. Healthcare workers exposed to blood or other bodily fluids as a result of needle sticks and mucocutaneous exposures are at risk for infection by bloodborne pathogens. According to an anonymous questionnaire of 505 healthcare workers, rates of sharp exposure and mucocutaneous exposure to blood are similar among healthcare workers. However, the reporting rates differ dramatically. Nurses inserting peripheral IVs may be exposed to blood leakage, spill, or splash during insertion procedures. However, estimates suggest that up to 83% of mucocutaneous exposures go unreported, whereas only 33% of sharps injuries go unreported. Peripheral intravenous catheter procedures can contribute to the risk of infection. These findings are from a 2011 survey of 404 nurses working in a medical surgical unit, an ICU, or an ED who perform peripheral IV insertions, removals, or even both. Nurses were asked, excluding needle sticks, to estimate how many times per month they experience mucous membrane or skin contact with blood during an insertion or removal of a peripheral IV catheter. Some of these participants were self-selected and were not necessarily representative of all nurses. But what they encountered were that it is pretty prevalent blood exposure. Technically, incredibly difficult sometimes to insert a peripheral IV. It is an invasive procedure, and it's often overlooked during in-servicing. Peripheral IV insertions and removals can put healthcare workers at risk from sharp injuries and blood exposures. In this same survey, contact with blood was found to be common during peripheral procedures. Needle stick risks with peripheral use are well documented, but exposure to blood during peripheral insertion and removal procedures could also put healthcare workers at risk of blood-borne infections. Greater than 40% of the respondents had at least one skin or mucous membrane contact with blood in a month during the peripheral insertion or removal. Almost 13% of respondents had contact with blood in their eyes, nose, or mouth at least one time that year during a peripheral insertion, and 12% of respondents had blood contact to non-intact skin at least one time during that year during the peripheral insertion. This same survey also asked nurses, think about your most recent blood exposure and how did it occur? Half of the respondents reported that the most recent blood exposure was due to blood leaking during the insertion from the catheter hub. Peripheral IV insertions and removals can put healthcare workers at risk of infection from sharp injuries and blood-borne exposure. Lastly, the third opportunity for standardization in our OR suites is through instrument handling and preparation. Here are 4 select opportunities to standardize instrument preparation in your facilities. Looking at education and training of the personnel on decontamination and sterilization processes, process improvements, instrument inspection and repair. Another avenue is instrument care and handling. Are you in compliance with guideline recommendations? Improving instrument tray oversight. Let's eliminate that excess of instrumentation and make sure our trays are accurate. And lastly, looking at electronic data collection, identifying of instrumentation inefficiency and variability. Are there reports and alerts that can guide us to implement a best practice? If we just focus on sterilization and disinfection of equipment in the operating room environment, recent news coverage serves as a reminder of the importance of proper instrument disinfection and sterilization. According to Joint Commission, 74% of all immediate threat to life declarations in 2016 were in fact related to improperly sterilized or high-level disinfected equipment. When proper equipment sterilization or high-level disinfection are not carried out, risks can turn into frightening realities. There could potentially be outbreaks of hepatitis B and C and HIV. Transmission of dangerous infection agents, including Pseudomonas, E. coli, MRSA, Salmonella, and even Clostridium, can all play factors. Standardization of cleaning procedures are an example of a way your facility can focus on standardization. Delays resulting from variability and inefficiencies can be costly. An average cost of time in the ambulatory care centers are anywhere between $29 and $80 per minute. So time is money. If we look at an ASC site that performs 2,500 surgeries annually, and 250 of those surgeries are delayed per year, an ASC could save anywhere between $7,250 to $20,000 by reducing delays by just 1 minute. Delays can be an example of missing instrument trays, looking for instrumentation, or improperly sterilized instruments that we've had to re-sterilize. Missing instruments can cause delays. There are electronic data collection systems that can help reduce variability by providing SPD technicians with essential information, such as instrument tracking, maintenance schedules, sterilization and non-sterilization warnings, tray prioritization, and inventory reports to identify instrument shortages. We talked about 3 ways to reduce variability, but what are some best practices in regards to infection control and prevention that BD can assist with? The BD Quality Solutions Program is focused on safety and efficiency for your ORs and SPDs. It is a 4-pronged approach: observe, design, implement, and sustain. During the observation phase, an on-site data collection and clinical assessment collects 80+ unique data points to establish a baseline of understanding of what your current state of practice is. It looks at products and policies. It designs a unique roadmap to better clinical practice and helps collaboratively review the decisions that are made. During the implementation phase, clinical skill development occurs, partnering and implementation of these recommended solutions, and targeted agreed upon performance metrics. Lastly, sustainability, measuring performance, documenting and reporting, checking competencies, ensuring sustainability within 30, 60, and 90 days of follow-up are just one example of many programs that BD has to improve safety and efficiency. What has been the impact of BD Quality Solutions programs? Well, over the past 4 years, we've had over 1,000 surgical facilities participate. With more than 28,000 surgical observations, we're able to have 1 publication and 4 posters generated. But I really want you to hear from a clinical director in East Tennessee ASC. This is what she says. After an extensive review, we introduced a multi-pronged educational strategy to drive improvement. We were able to bring post-procedure infection rates down by 80%, increase staff consistency and satisfaction, and improve patient experience. BD has a dedicated ambulatory care center team. We've got 25 special representatives, 5 managers, and 2 national account specialists that can help with your educational needs. BD has a dedicated ambulatory surgery center portfolio that includes patient preoperative skin prep, surgical instrumented care, hemostasis, vascular access, medication delivery and sharps disposal, and anesthesia and pain management solutions. In conclusion, more surgical procedures are taking place in the ambulatory surgical centers every year. The patient experience may soon impact quality scores. Infections are a risk of ambulatory surgery centers. They're threatening patient and worker safety as well as delivery of quality of care. Safety and quality improvement to mitigate risks of infection can be achieved with standardization, processes, technology, and behaviors selected for standardization can be grounded in evidence and adhere to recommended practice. Thank you for your time today. If you have any questions on any products from BD or our programs that we provide, please do not hesitate to reach out to your local representative. Thank you again and have a wonderful day.